were really interested in having a look at the clinical leadership role in Australia because we have had now a history of meso level, so intermediate level organisations in primary healthcare for some time, but there's not very much research that's been done to identify what the particular strengths are of those roles and how they work in the system. And the evidence that we'd had from overseas, particularly from the UK, which is a not dissimilar system, was that the role of a clinical leader was actually really important in the translation of research evidence, but also really important in some of the developmental roles in networks and the strengthening of networks in terms of getting primary care organisations and clinicians on the ground to undertake a more structured set of research activities in primary care and translate that evidence. And at the same time, there was quite a lot of evidence coming out that there was a really clear role for clinical leadership in starting to set the strategic direction of meso-level organisations, so middle-tier organisations, so that policies were able to be implemented on the ground and there was able to be feedback from the ground up about the best way of managing the translation of research into practice.
One of the greatest challenges always has been the translation of learnings from research into practice in a sustainable way, in a systematic way, in an effective way. So the challenge we were really trying to resolve or try and get some learnings about was in relation to that. It was about how do we systematically translate research into practice, and how do we make the information flow the other way as well.
So what we were really trying to explore was how could we add some additional depth to the organisation's credentials by building in a GP leadership role into the structure of the organisation, into the actual organisational structure, as opposed to the governance and advisory arrangements. We saw the role benefiting the organisation really in three main ways. First of all, we saw the role adding to our capacity and I suppose the degree to which we took a sophisticated approach or a more sophisticated approach to evaluation and translating research and knowledge into the way we design programs and services. So that's the first point. The second point is that we wanted to take a more mature and structured approach to the way we supported our general practice community. So the role was very much beneficial in that sense as we redesigned our education program. And then the last benefit was its the value add in terms of our strategy development and our positioning as we framed our approach to evolving into a primary health network. We very much drew on the expertise of the role and the exposure that the incumbent in the role at the time had to commissioning in the UK context, the exposure and expertise they had in clinical leadership and quality improvement, and how you build that into a commissioning for value approach, which was really the underpinning philosophy for our primary health network blueprint. Because we were taking a capacity building approach, I think one of our learnings was that you can't rely necessarily on one position to change that culture towards a more clinically relevant, clinically led organisation. You've got to permeate clinical leadership and that concept of clinically literate managers and managerially literate clinicians at all levels through the organisation. And I think if we had a bit more time, we would have reached that point.
One of the biggest challenges for the role was to do with a federal government change within a few months of starting the role. The idea behind the role was the translation of research into practice. About 2.5 months after starting the role, the federal government announced a reform of Medicare Locals into primary health networks, and that just changed the whole focus and the priorities of the program, and therefore the role as well. So what really happened was the initial work program we'd thought through and thought about and co-designed and planned all went up in the air really, and the focus became the tendering for the primary health network. One of the greatest successes of the role, bearing in mind this role was about translation of evidence into practice, and I think when the role was conceptualized, I think we were really thinking about the translation of clinical research into practice. But with the government change and the reform to primary health networks, the focus changed, and the role really had changed priority. As part of that priority, I started to look at the research evidence around primary healthcare organisations from around the world, what that had showed as being the enablers, the success factors, but also the barriers. And that piece of work, that piece of literature review, I think was really helpful in formulating what became the tender for the primary health network and for which the organisation was successful.
There were multiple benefits to the role, many of them implicit rather than explicit. For example, just having Paresh available to actually pick his brains, access his networks, and just gain that informed sort of knowledge and insight was incredibly helpful on a day-to-day basis. So physically just having him available to us was hugely beneficial to everyone within the organisation. The role supported the translation of research into practice by, first of all, making sure that the most timely and relevant research evidence was available to us, and then helping us actually unpick what was relevant to us within our context at that point in time, and how we could actually shape our policies and strategies to build on that evidence base.
Well, from the evidence that we had, we understood that a lot of the perceived value would be in the translation of research. But I've got to say that one of the things that we found was that for most of the people who were program connected at the Medicare Local, the perceived value was very much having that expertise available and on the ground.
Having the clinical lead with research access and an understanding of the role of primary healthcare organisation was hugely beneficial to us, because what that meant in practice was around the fact that we could actually take the learning from primary healthcare organisations around the world, look at how they were modelled, look at how they developed, and then look at how we could actually contextualise that within the Australian setting and within our health system as such. So from that, we were able to understand what best practice was of a primary healthcare organisation, what the key role and function of a primary healthcare organisation was, and what the key challenges were in developing effective primary healthcare organisations. And then it helped us shape the organisation both in terms of function and structure, so pulling together a fit-for-purpose organisation that would see us through into the future under the Primary Health Network programme. So that was hugely successful from our perspective.
The impact of the role, I think, most strongly was felt in providing clinical advice into the strategic planning for the next stage of the primary care organisation. So as the organisation moved from Medicare Local to Primary Health Network, the clinical leadership had an enormous role, I think, in clarifying and working out what would be the most appropriate way for the organisation to go forward.
For me, the biggest learning was 1 year was probably too short to demonstrate any real value, any real impact. But I think anecdotally, when we speak to people within the organisation, certainly there was a sense that the role was valuable, it was useful, it had impact. But to be able to demonstrate that in research terms within a 1 year timeline, I think is really, really hard. It's a very complex intervention. But it's really interesting that when you look at international healthcare systems, they're all going for the same purpose, they're all going for the purpose of the quadruple aim, improving patient outcomes, improving the experience of the workforce that's working within that system, doing it at better cost or reduced cost, so being cost effective with it and improving the experience that patients and consumers have when they have an experience or an encounter with the health system. So the international literature was really, really important because each health system was striving for the same purpose. Although the context was different, the goal was the same, and therefore the learnings from those different systems became really important for us.